Welcome to Clinical Minute. Natalie is a 25-year-old woman, gravida 0, para 0, who presents for her annual Well Woman visit. She also wants to discuss contraceptive options today and is interested in taking DMPA, depomedroxyprogesterone. Natalie is 5 foot 7 inches, 124 pounds, does not smoke, and consumes alcohol occasionally. You complete a physical exam, including a pap smear and pelvic exam. As part of your annual Well Woman exam and contraceptive options counseling process, you tell her that you would like to ask her some questions about her medical and sexual history, diet, and activity level. She nods her head yes. During the sexual history, Natalie shares she has been single and has had several sexual relationships with men since her late teens. She is currently in a sexual, monogamous relationship with a man she has been dating for a year. When you ask about her menstrual periods, she shares, "Since my late teens, my periods have been pretty irregular. In the last couple of years, there have been times when I haven't had a period for months." You ask her when her last menstrual period was, and she replies, "I think I had one 5 or 6 months ago, but I know I'm not pregnant. I took a home pregnancy test last month." Natalie shares that she started her periods at age 14 and began taking oral contraceptives at age 16, which she has taken off and on since. You ask about her exercise routine. Natalie says, "I run every morning and go to the gym 5 times a week for spin classes, weightlifting, and to use the elliptical machine. I started running cross-country in high school and have been a runner ever since. I started running marathons when I was 20 and now run about 3 marathons a year." You then ask her about her diet. "Can you tell me a bit more about your food intake and diet?" Natalie seems a little hesitant at first, then responds, "I've had some issues with food off and on since high school. My parents were always on me to eat more. I try to eat healthy, but I won't let myself have a lot of calories unless I know that I'll be able to run it off. My diet is mostly salads, chicken, and vegetables, very few carbs like pasta. I will sometimes skip meals on the days leading up to a race so that I'll be as light as possible." You have heard about the Female Athlete Triad and are concerned Natalie may fit this profile, considering her amenorrhea and high level of physical activity. The Female Athlete Triad is a medical condition often observed in physically active girls and women, which involves 3 components: low energy availability with or without disordered eating, menstrual dysfunction, and bone loss or osteoporosis. Female athletes often present with one or more of these 3 triad components, and early intervention is essential to prevent progression of female athlete triad to serious endpoints that include amenorrhea, clinical eating disorders, and osteoporosis. Amenorrhea is usually the first sign that alerts clinicians to the presence of this triad. Numerous health consequences are associated with female athlete triad, including excess fatigue, increased recovery time, gastrointestinal disorders, negative consequences to current and future bone health such as stress fractures, increased risk of future osteoporosis and fractures, and impaired future fertility. Energy availability, or the amount of dietary energy remaining after exercise training for all other physiologic functions each day, directly affects menstrual status. In turn, energy availability and menstrual status influence bone health. Poor nutrition and disordered eating are thought to add to the risk of bone health problems in female athletes. Athletes like Natalie who participate in marathons may be prone to developing eating patterns that contribute to both menstrual irregularities and a state of weakened bones. Severe undernutrition, low energy availability, impairs reproductive health, low estrogen and progesterone, and skeletal health, low BMD. As you obtain more information about Natalie's habits and lifestyle, you realize that it is essential to explore another component of the female athlete triad in this patient: bone loss and osteoporosis. You ask Natalie if she has had any fractures, such as stress fractures, as an adult. She replies, "I had a stress fracture of my foot about a year ago. My doctor put me on crutches for 1 month, and he made me promise to stop running for 3 months. That was really hard." Bone stress injuries, including the spectrum of stress reactions and stress fractures, are more common in female athletes with menstrual irregularities and/or low bone mineral density, or BMD. The stress fracture that Natalie experienced a year ago may indeed be linked to low bone mass. Moreover, it is not necessary to have all 3 components of the female athlete triad simultaneously for resultant negative effects on bone. What is your next step for educating and counseling Natalie about her risk for further stress fractures and osteoporosis? To address low BMD in athletic women who may fit the female athlete triad profile, energy availability must be increased. The etiology of bone loss among amenorrheic women includes energy deficiency-related factors and estrogen deficiency. Thus, weight gain and subsequent resumption of menses are key to prevent further loss of bone mass. There is evidence that supports the positive effect of weight gain alone on BMD. Weight gain independent of resumption of menses has been shown to have a positive effect on BMD and to restore the coupling of bone formation and resorption. Weight-bearing exercise is a primary non-pharmacological strategy for increasing and maintaining BMD across the lifespan. Improvements in femoral neck and lumbar spine BMD have been observed following weight-bearing exercise training clinical trials of premenopausal women. However, patients with female athlete triad should actually reduce their exercise frequency or intensity while increasing their calorie intake to restore energy availability, specifically reduce energy deficit, and regain menses. Calcium and vitamin D status should also be addressed. You tell Natalie you are concerned about her bone health and risk for osteoporosis. You also tell her that she is at a higher risk for osteoporosis and further fractures because of her high level of physical activity, eating habits, and menstrual disturbances. You explain the components of female athlete triad and how she fits within this phenomenon, as well as her contraceptive options given her risk of osteoporosis. You know the 3 components of the female athlete triad recover at different rates with appropriate treatment. Recovery of energy status is typically observed after days or weeks of increased energy intake and/or decreased energy expenditure. Recovery of menstrual status is typically observed after months of increased energy intake and/or decreased energy expenditure, which improves energy status. Recovery of BMD, however, may not be observed until years after recovery of energy status and menstrual status has been achieved. You counsel Natalie that there are things within her control that she can do to help reduce her risk of developing osteoporosis, including increasing her calcium and vitamin D intake. You also refer her to a dietitian to discuss her diet and her eating habits, in hopes of reducing her risk of osteoporosis and achieving a healthy weight. She nods her head yes and agrees to see a dietitian, saying, "That's probably a good idea." You return to her request for a contraceptive method and address her interest in DMPA. You know that studies have shown that depo affects the BMD of different bones differently and can impact the spine and hip, with the femoral neck being particularly vulnerable to BMD loss. You suggest to Natalie that depo may not be a good option for her, since women on depo tend to experience a loss of BMD, and side effects include changes in menstrual periods. Applying patient-centered contraceptive options and counseling principles, you counsel Natalie on her options, which include the vaginal ring. She decides to try this method of contraception, and you write a prescription for it. You advise her to return in 3 months for a follow-up visit.